Dear students, we will discuss an operative procedure today, which is quite common, often asked as a operative procedure technique during Viva and exam. And theory also they will ask, MCQ they will ask so many things. So just have a brief idea, then you can go through my manual of surgery to have a detailed discussion about this procedure. So what is this procedure is? Nothing but the position for thyroidectomy, all of you know. The rose position, name of the position is rose position. And what are the steps? See that, see the incision. So patient is under general anesthesia. Initial evaluation with the vocal cord assessment by using indirect laryngoscopy or video laryngoscopy you can see and assess properly. Our stroboscopy also can use, and serum calcium level should be estimated. T3, T4, TSH, FNA, everything should be assessed properly, and cardiac assessment should be done. And under GA, with head up position 5 to 10 degree to reduce the venous congestion and bleeding, and neck extension by placing the sandbag under the shoulder blade, hands tucked under the buttock, and double draping after cleaning and draping. Skin incision is 2 finger breadth above the sternal notch from one sternocleidomastoid to the other sternocleidomastoid muscle. Skin and platysma should be incised, and so subplatysmal plane. Upper flap is raised up to the thyroid cartilage. Lower flap is elevated up to the sternoclavicular joint. And using jaws retractor it is held, or using silk sutures you can keep it away. Then once you control the bleeding, then and there only using cautery, monopolar cautery. You can use monopolar cautery at this juncture, but not close to the recurrent laryngoscope and parathyroid gland, where you have to use only bipolar as much as possible, or judicial use of cautery. That's important. And open the pretracheal or investing layer of deep fascia vertically in the midline. Then identify the strap muscles. If a large thyroid has to be cut by placing 2 cockers forceps. Then dissect adequately properly. Open the pretracheal fascia. Then you can see the thyroid gland, and start one side dissection. Medialize the thyroid. Identify the middle thyroid vein. Middle thyroid vein is there. There is no middle thyroid artery. It is short, stout joint, the IJV, and ligate it. Double ligation you have to do. Sometimes the middle thyroid vein may be absent. Then superior thyroid pedicule has to be ligated. You have to identify the superior external annular nerve. Then ligate superior thyroid artery and vein separately. That is the current concept. Even though commonly used is either ligate the superior thyroid pedicule close to the gland, not away, so that avoid injury to the external annular nerve. If you injure external annular nerve, patient it's like cricothyroid. So pitch of the voice is lost. So individual can't speak continuously, especially teachers or singers. It will be problematic because pitch is lost. So pitch is maintained by the cricothyroid or otherwise external annular nerve. So you have to avoid injury to that. And then identify the recurrent annular nerve, identifying the Berry's ligament and Zucker canal tubercle of the thyroid posterior upper part. It's called lateral anal gate, that is called Zucker canal tubercle, very close to the recurrent annular nerve. Then dissect carefully once you identify these structures and parathyroid glands. Then ligate the vessels very close to the gland. Olden days, inferior thyroid artery is to ligate wherever it comes out of the carotid in continuity. This is not the current concept. Ligate very closely so that retain the anastomotic branch of the inferior thyroid artery, which supplies both the parathyroid, superior and inferior. Then after that, medialize the thyroid. Do the dissection on the opposite side also, and isthmus should be dissected, and pyramidal lobe is there is also dissected, and gland should be dissected off the trachea, then removed. All bleeders should be controlled by proper hemostasis using bipolar cautery and careful use of monopolar as much as monopolar lateral heat may injure or cause neurophaxia or injury to the recurrent annular and parathyroid. That is the point you have to remember. Once you had a hemostasis, remove the sandbag. Then again confirm the bleeding, give a warm saline, watch cease for the bleeder, then push a suction drain, then close the fascia muscle. If you have cut or trap muscles, you can suture with the vicryl absorbable suture, then close the investing layer of deep fascia what you have opened vertically, that also goes with the vicryl, then subcutaneous and the subcutaneous suture you can put and put the dressing. Always observe for the hemorrhage, laryngeal edema, parathyroid insufficiency by checking the serum calcium, then recurrent annular vocal cord you have to check always after the surgery, then bleeding, then or the different thyroid storm if patient is toxic. So different complications which you have to remember. on table, early, immediate post-op and late post-op. That is how we're being classified. Late sequelae after total thyroidectomy, the mixed edema, we have to supplement the patient with the maintenance dose of L-thyroxine 100 microgram. Always give morning before food. So that is a brief technical aspect of the thyroidectomy, because in some they will ask, you have to know the complications, position, methods, how exactly middle thyroid vein first, next superior thyroid pedicle, then inferior thyroid pedicle, recurrent plungin or parathyroid. So the two important structures we have to retain to avoid injury or deficiency of these structures. This is the point you have to remember. Raising the flap also, all those things are important. So these are the steps. You can see that raise the flap, very large thyroid here, upper flap, lower flap here, sutures. This is the Jawl's thyroid retractor. Remember, MCQ question, Jawl's. I think I have shown this instrument in earlier lectures. You can go through that lecture. So I have the idea about the Jawl's thyroid already earlier brief lecture, evening time, which I have sent earlier. It is there. So please go through that. Jawl's thyroid retractor and see that flap, see the specimen, total thyroidectomy specimen. Always send it for histology. Mark right side, left side, upper pole, lower, so that pathologist will have the idea which side it is there, which side it is the superior pole. So that point also, marking also important poles to have the identification. Then always place the train and close. So complications I have already told: tracheomalacia, respiratory obstruction, thyroid storm, hypothyroid, mixed edema. You can always go through my service manual surgery thyroid chapter in detail. Everything is given about thyroidectomy with the diagrams, with the different types: hemithyroidectomy, total thyroidectomy, near total thyroidectomy, partial thyroidectomy, subtotal thyroidectomy. So the different types, meanings I have given, indications. Please go through my manual of surgery thyroid chapter, which gives detail about the different aspects of the thyroidectomy, including detailed complications as such. So these are exactly classified: metabolic, respiratory, vascular, neurological classification, intraoperative, immediate, early, post-operative. I have discussed all these things while giving the explanation. So students, go through my SRB's manual of surgery and clinical method of surgery, and also request please subscribe my YouTube channel. It is free, and daily small brief lectures will come so that you can upgrade your surgical knowledge with the spending 5 to 10 minutes daily. So the clinical scenario, images, X-rays, instrument, post-operative procedures, and at regular live sessions of long discussion of the case presentation by students with the senior faculty around in the online platform. And you can all put it in the chat box and get the answer and doubts. And it will be very useful for your exam, practical exam. And also you'll get a certificate if you join the live session, which will be useful for your future career as well. So please subscribe my YouTube channel. So answer the MCQ. I'll get back to you with I will acknowledge your answer. Put it in the comment box. Surgical avascular pain is located in thyroid in A, B, C, D. Find out the right answer. Put it in the comment box. A 50-year-old male came with large recent onset thyroid swelling. FNAC showed plenty of amyloid. Ideal blood test to diagnose is TSH, thyroglobulin, calcitonin, calcium. Put the right answer in the comment box. I will get back to you. So quotation of the day is: don't compare your feathers to another's. Your wings are perfect for your sky. So what you are is you are. Be contented with what you are. Be happy with what you are. Be proud to be what you are. This is what exactly. Always be proud of yourself, but don't be egoistic. That is what exactly it means. That is the quotation of the day. Again, I request students, please subscribe my YouTube channel. Please subscribe my YouTube channel. It is free. And also have my SRB's manual of surgery and clinical methods of surgery for your surgical career to understand everything about surgery. So students, please go through my SRB's manual of surgery. It gives a detail about the all CBMA syllabus and covers both for MBBS and postgraduate also. But we got MCQ for each topic wise: general surgery, gastrointestinal surgery, urology, specialty basics, urology, neurosurgery, cardiothoracic, all those basics are covered. Instruments, adjuvant therapy, chemotherapy, briefly about anesthesia, specimens, briefly about anesthesia, briefly operative surgery, and current recent advances also. Everything covered with the quotations, with the illustrations, with the photos. Everything is covered. It's more than sufficient for undergraduate to go through this book, learn surgery, and face exam, place MCQs, everything for both UGs and postgraduate. Also go through my clinical methods in surgery with the video of how to examine in each topic. It gives a detailed examination method, but of course there is no management in this. It's a clinical book. and briefly in a tabular form differential diagnosis and good photos and exactly how to examine and how to write case sheet of each different topics, ulcer, swelling, breast lump and everything covered. Briefly orthopedic also. It also has got specimens, images, instruments which can always be useful when you take Viva and Oxy and practical exam. So very useful because you have all videos of how to examine a patient. It's very important in your practical exam of any medical graduate of any type. It will be very useful. So please go through it and have it. And my operative surgery, the 2-volume book, new edition has come, and it was extensive discussion about the methodology, technical principles, and steps of the different operations, major to minor. Everything is covered with around 10,000 illustrations and photos. And my tissue atlas of tissue approximation, small 100 pages book with the video, how to do suturing in different situations properly with the video. It has shown very well, and can always go through that. And my DigiNow lectures through JP Publishers, around 220 hours, covers everything, A to Z topic, virology, specimens, instruments, clinical examination, videos, everything it is covered. Please, you can purchase for a year so that you will have the clear idea. You can face the exam, have the clear idea, academic part, everything. Will have entire subject is covered, including clinical part. So please purchase and have a clear idea about subject and to face the. So students, I hope you understood this topic very well. Thank you so much.